Welcome, and thank you for joining us today for this important discussion on the current strategies and challenges of intracerebral hemorrhage. I'm Karen Furie. This event is part of a series of webinars created through the collaboration of the World Stroke Academy and the American Stroke Association. For this discussion today, we have a stellar panel of experts. Craig Anderson is Director of the Global Brain Health Program at the George Institute for Global Health and Professor of Neurology and Epidemiology at the University of New South Wales. Steve Greenberg is Professor of Neurology at Harvard Medical School, Director of the Hemorrhagic Stroke Research Program at Massachusetts General Hospital. And Wendy Ziai is Professor of Neurology, Anesthesia, and Critical Care Medicine at Johns Hopkins University Medical Center and co-director of the Neurocritical Care Unit. For questions during our presentation, our live audience will be able to submit questions using the Q&A box. Submit your questions at any time. You may also use the chat feature to say hello. This webinar is being recorded and will be made available for on-demand viewing. At the conclusion of this activity, our objective is that you will be better able to evaluate recent advances in the diagnosis, treatment, and prevention of intracerebral hemorrhage, identify best practices for rapid triaging and care plans for multi-specialty interprofessional teams, and appropriately use neuroimaging to improve functional outcomes and reduce mortality due to hematoma expansion. I'll now turn the slides over to Dr. Anderson.
Hello, everybody. It's a great pleasure to participate in this session. My job is to start off setting the scene with the big picture on the burden of intracerebral hemorrhage. These are my conflicts with grants from both industry and government and some leadership roles. I think you all appreciate that in high-income countries, most of us online are from a high-income country. Intracerebral hemorrhage accounts for about 10–15% of all stroke cases, but in low to middle income countries, it's on average about a fifth, 22%, but can be up to half of all strokes intracerebral hemorrhage. I think we know that. What's less appreciated is that the disability adjusted life years associated with intracerebral hemorrhage is actually greater than it is for ischemic stroke. That trend has been declining over the last few decades, but it's still substantial. So on a global basis, intracerebral hemorrhage is the more disabling and disruptive to the lives of people. And part of that's because it affects people at a younger age and has higher mortality and disability. Around the world, there is a lot of variation in the rates of intracerebral hemorrhage. This is data from the Global Burden of Disease study. And even within countries, there are differences in rates across particular ethnic groups. And I want to draw out that intracerebral hemorrhage follows a pattern of deprivation, so low resource environments and lower socioeconomic groups. And in part, that's related to hypertension and the dietary factors associated with that. You can see on this map where the high intensity red is, and particularly in the landlocked country of Mongolia, just to highlight the pattern of intracerebral hemorrhage there. I've had the fortunate opportunity to work with researchers there over the last few years, and we've just published this epidemiological study of stroke in Ulaanbaatar, the capital of Mongolia. And the rates of hemorrhagic stroke here are several-fold greater than in any other population-based study. So it's an unfortunate highlight of this country as being the intracerebral hemorrhage capital of the world. And then you look at the pattern in the cases of intracerebral hemorrhage, average age 59. That's 20 years younger than in the West. It's driven predominantly by hypertension, but there's also other lifestyle factors going on, hypercholesterolemia, obesity, alcohol and smoking. But down the bottom here, you can see that the overall 28-day case fatality is 53%, and by 1 year, over 80% are either dead or disabled. So this is a huge burden on the population, removing very productive people from society. Now, a major driver of intracerebral hemorrhage is hypertension. This is data from the Kadoorie Biobank study, a large population-based study, prospective in China of 500,000 people that have been followed up now for almost 15 years. You can see on the left, the relationship between baseline blood pressure and intracerebral hemorrhage is very steep in comparison to ischemic stroke and ischemic heart disease. And consequently, then, if you could reduce blood pressure by 10 millimeters, which is generally what you can achieve with 2 antihypertensive drugs, you get a much larger prevention of intracerebral hemorrhage than for other ischemic vascular events. And so if we think about hypertension, what are the drivers of this? So returning to Mongolia, which is intracerebral hemorrhage capital of the world, big problems there around diet. So very heavy intake of salt. Recommended intake by WHO is 4 millimeters per day. And in Mongolia, it's around 14. And very salty tea is a regular intake, but also is related to fresh fruit consumption. This is quite difficult to bring into Mongolia, and these data arise again from the Kadoorie Biobank study, looking at usual consumption of fruit per day, and you can see linear relationships with major cardiovascular events, but again, steeper relationship in terms of prevention of hemorrhagic stroke for frequent fruit consumption. So that's observational. Where's the data that we can actually modify vascular events by changing the diet? So this is the seminal clinical trial. I think this is probably the trial of the decade, which was led by Bruce Neal from the George Institute, looking at a low sodium potassium enriched salt to be used for cooking at home amongst villages in rural China, followed up over almost 5 years, and looking for an assumption of a reduction in stroke with a very modest difference in systolic blood pressure achieved by dietary manipulation. And lo and behold, on all of the endpoints, there was a substantial benefit. In fact, a very substantial benefit in all-cause mortality. It's very rare to find that in a cardiovascular trial these days. And this all occurred without concern that the potassium enrichment would cause hyperkalemia. So that's all well and good to modify salt in a rural community where most of the cooking's at home. But in our society, most of the salt consumption's in processed food, canned food, meat, cheese, bread. So if we're going to do anything about modifying our salt consumption, we have to work very closely with industry and government to reduce that. And then modifying our own individual consumption, it's quite tricky, and we're all familiar with the dietary pyramid, but we have to move towards more plant-based food and think about food from a global point of view. There are various strategies that are being examined now to look at how can we modify food intake through school children education, think more about planetary health, food supply and medically tailored meals. And there's some trials going on to examine this sort of targeting of food intake. The other way, obviously, is better hypertension screening. This is a very successful program. May Measurement Month coming up, led by the International Society of Hypertension, and more screening and then targeting and bringing people onto treatment for blood pressure control. You don't need doctors for blood pressure control. Here's another trial recently completed in China looking at lay workers, finding people with hypertension, using an algorithm to manage their blood pressure, and again, substantial reductions in cardiovascular events with very good blood pressure control. Now, this took over 3 years to achieve blood pressure targets. You can actually do that much quicker. We've been working on triple low-dose combination antihypertensive, 2 trials that we've done with this combination algorithm, very effective blood pressure control, achieved much quicker, more sustained with less side effects in this approach. And that's actually what the WHO recent hypertension guidelines are, is to start on combination treatment. It's very rare now that hypertensive patients require a single agent, so combination of agents, and particularly people with intracerebral hemorrhage where blood pressure is so strongly related to their risk of disease. Just think about just maximising blood pressure control. I'm leading a big trial to examine this approach, a triple combination of low-dose telmisartan and lobodipine in indapamide. We've just passed 1,200 patients randomised, and hopefully we can achieve our target there to show this approach works well to bring blood pressure under control safely and continuously in people with intracerebral hemorrhage. So just to summarise, intracerebral hemorrhage, enormous global burden. It does track where there's deprived low resource populations driven by hypertension, dietary approaches. We need both population-wide approaches, high-risk approaches. Potassium-rich, low-sodium diet is something that could be widely applied, but to be effective, that requires a multi-strategy approach, both with industry and government. We quite like the triple or polypill approaches, again, in low-resource settings. Industry have these pills, but they're a bit expensive at the moment, so we need low-resource approaches, low-cost approaches to use that. And finally, intracerebral hemorrhage, again, it's all down to blood pressure control, better screening, push the blood pressure. Thank you very much, and I'll pass over to Steve next of all.
Thanks very much, Craig. And yeah, it's the next, both my talk and the following talk from Dr. Ziai will focus on guidelines that were published from the American Heart Association, American Stroke Association in just the past year. So I will start with a group of topics with detection, etiology, and prediction and prevention of intracerebral hemorrhage. These are my disclosures, and none of them are related to the current presentation. And here my thanks, as I mentioned, are to Dr. Ziai, who will be the following speaker, the co-chair for the development of these guidelines, and to the writing committee that you see here, that anyone who's familiar with the American Heart Association, American Stroke Association process knows it's an extremely rigorous process, very demanding on the members of the writing committee. And what you see here reflects both the full input of the writing committee shown here and a large number of societies that commented very fruitfully on the guidelines and improve them. And the summary slides that will be kind of sprinkled through the talk as I show are ones that were developed by the AHA guideline ambassadors shown at the bottom of the slide. So let me turn to the topic. So as to start with detection and etiology and sort of putting them into one breath because of the role of neuroimaging in identifying etiology. So the CT scan is clearly the gold standard for widely available, at least in both high and middle income countries, for sensitive detection of acute intracerebral hemorrhage. And then particularly in high income countries, the role that MRI has taken on, particularly the T2 star weighted blood sensitive sequences. And I'll come back to that a little bit as we go in terms of role also for prognosis for recurrent hemorrhage. So broadly speaking, the etiologies of intracerebral hemorrhage can be divided into three groups, which have really been subsumed even into two groups. So the top two listed here, arteriolosclerosis and cerebral amyloid angiopathy, are the major small vessel diseases associated with intracerebral hemorrhage. And then a large heterogeneous group are grouped together under this secondary or macrovascular etiologies. The terminology is a little challenging here because we'll often refer to the top two as being spontaneous. Well, of course, they're not truly spontaneous. They reflect an underlying etiology, just as the macrovascular ones do. That has been generally more challenging to identify those small vessel diseases, although it's an area that we clearly have improved in and can often make a clinical diagnosis as to the small vessel disease. But to focus on how we differentiate these, and really the location of the bleed serves as a very useful first indicator of the underlying etiology. And shown here are the major locations and associated etiologies for so in the deep territories, referring to the basal ganglia, thalamus, and brainstem, and posterior fossa in general. Arteriolosclerosis is likely the most common etiology and clearly the most common of the two small vessel diseases. Macrovascular causes also can occur in these deep penetrating territories. They make up a proportionally lower a fraction of the hemorrhages in those territories, whereas in the lobar territories, so referring to the cortex or the gray-white junction or underlying white matter, cerebral amyloid angiopathy is the major small vessel disease, although arteriolosclerosis can also cause hemorrhages in the lobar territories. And macrovascular causes are also major etiologies and probably proportionally a larger fraction than they are for the deep and posterior fossa territories. And although the remit of our writing committee was not to focus on the macrovascular causes, it still, of course, is relevant to how to identify those among the group of all intracerebral hemorrhages. And the results here are similar, shown from the diagram study run from the Dutch investigators, are similar to studies from other investigators, as well as identifying particular clues that that a hemorrhage may have an underlying macrovascular cause. So those hemorrhages in younger individuals, in lobar locations, without other evidence of small vessel disease, such as white matter hyperintensities or lacunar infarcts, are more likely to have a secondary macrovascular cause and therefore have higher yield if undergoing further vascular imaging to try to find a vascular macrovascular cause, a large vessel cause. And in addition, individuals who have some imaging evidence on non-invasive studies such as CT angiogram that have indications of a macrovascular lesion, not surprisingly, in fact, do have a higher proportion of macrovascular lesions when further evaluated. So that leads to these guidelines that came from our writing group in terms of who should get additional studies. So individuals who have lobar hemorrhages at somewhat younger ages, so less than 70, or the deep or posterior fossa intracerebral hemorrhages either at quite young ages, less than 45, or in that intermediate 45 to 70 range, but without evidence for hypertension. It was a class 1 recommendation to have them undergo at least CT angiogram and venogram to look for underlying macrovascular cause, and other either MRI, MRA would be reasonable. Cerebral angiogram is felt to be reasonable, but not strongly indicated in those situations. Cerebral angiogram or a DSA angiogram is more firmly recommended for people who either have intraventricular hemorrhage because of the high proportion of vascular malformation associated with intraventricular hemorrhage, or who have any suggestion on their non-invasive imaging of a macrovascular cause. Then DSA is recommended at the class 1 level. So I'll come back to small vessel etiologies when we talk about prediction of recurrent hemorrhage. But first, the term prediction actually sort of covers two different kinds of prediction. One is predicting hematoma expansion, which clearly is an important contributor to a poor outcome in individuals with intracerebral hemorrhage. So CT scan is generally used as the state of the art for detection of initial hemorrhage. And then serial CT scans were recommended at the class 2A level as potentially useful to look for hemorrhage expansion, and in particular in people with poor neurologic exams who could not easily be followed just by exam alone. And then serial imaging beyond that first 24-hour scan for stability is open to interpretation by the clinician as to whether it's still indicated or whether the patient has a stable enough exam and enough findings to be able to be followed just clinically. But the other use for imaging is as a way to identify individuals who are at higher risk for hematoma expansion. And this is still an open question of what we can do with that information. We don't yet have well-established treatments beyond blood pressure control for limiting the risk of hematoma expansion, but prognostically, it still nonetheless is felt to be at least reasonable to consider the incorporating markers into predicting hematoma expansion. So what are those markers? Well, the spot sign has been around for some time now, so that's evidence of as shown in the lower left here of contrast enhancement on the CT angiogram within the hematoma itself, likely a marker of ongoing bleeding within the hematoma. And excitingly, although still at a bit of a preliminary stage, are the wide range of markers of expansion risk that can be seen on non-contrast CT scans. And the idea here, particularly these different kinds of inhomogeneities within the hematoma, likely also are markers of ongoing bleeding and carry substantial information about risk of future hemorrhage. And it's still future expansion, and it's still an open question as to whether one of these markers is better than the other ones or how to incorporate the multiplicity. This was a meta-analysis performed a few years ago by Andreas Moratti, and looking across these different signs, the black hole sign, blend sign, and so on. And they seem to carry similar weights. So there's not yet consensus, and the committee did not feel that there was enough information to select one of them as the ideal marker. And we hope by the time these guidelines roll around for further update that we'll have consensus as to individual non-contrast CT markers that might be used to predict expansion, but clearly an area where there is information to be gained and hopefully applied to, as we have more treatments, to limit expansion. The other form of prediction is predicting recurrent hemorrhage, and this is clearly, though the initial hemorrhage has a substantial impact and is associated with substantial morbidity and mortality, recurrent hemorrhages are associated with particularly poor outcome. And the major factor here for predicting recurrence is that distinction between the two small vessel diseases. I mentioned the arteriolosclerosis and cerebral amyloid angiopathy. And in this pooled analysis from Andreas Charidimo working with David Waring, you see this very substantial difference between intracerebral hemorrhages that were felt to be unrelated to CA, primarily arteriolosclerosis, versus those related to CA. So that 1.1% recurrence rate is substantial, but is dwarfed by the 7.39% per year recurrence rate among intracerebral hemorrhages felt to be related to amyloid angiopathy. So to a substantial extent, if we can identify CAA-related hemorrhages, then we can also go a long way to identifying the risk for recurrence. And the markers that have been used primarily for diagnosis of cerebral amyloid angiopathy are the strictly lobar microbleeds identified in the Boston criteria as having a substantial specificity, and more recently the addition of either convexity subarachnoid hemorrhages or cortical superficial siderosis, particularly when multifocal as a marker of cerebral amyloid angiopathy, and also of recurrent hemorrhage among amyloid angiopathy patients. So the guidelines read that incorporation of the available MRI information on cerebral microbleed burden or the presence of cortical superficial siderosis can be used to inform decision-making for primary prevention. This was the first time the guidelines had touched on the potential role of these markers, even in people who've never had a prior intracerebral hemorrhage, and likely all the more so for recurrent hemorrhage. Well, the etiology, this amyloid angiopathy versus arteriosclerosis, is a key factor for predicting recurrence, but certainly not the only factor. And this goes very much back to these slides. This comes from Alessandro Biffi working with John Rosen, showing that the clear relationship between measured blood pressures over time and intracerebral hemorrhage recurrence. And as you can see, that's true both for the deep hemorrhages felt to be due to arteriolosclerosis with a major component of hypertension in their etiology, as well as with recurrent hemorrhages. And here we're really, this dovetails very much with Dr. Anderson's presentation on the role of blood pressure as a major risk factor for first hemorrhage, and clearly is true for recurrent hemorrhage as well. And the other predictors, and these probably relate to, again, to some of the factors discussed by Dr. Anderson. This is work that Kevin Sheth led, looking at California hospital databases, finding that at least in this group, that both Black race and Asian race were associated with higher risk of hemorrhage recurrence, and private insurance was associated with lower risk, and almost certainly that's insurance status is heavily confounded both with medical care and likely with other lifestyle and food choices as well. So these are likely markers of a wide range of social determinants associated with a risk of recurrent intracerebral hemorrhage. So the guidelines with regard to prediction of recurrent hemorrhage are the use of the lobar location of the hemorrhage, older age, presence of markers of amyloid angiopathy such as microbleeds and cortical superficial siderosis, all as markers for recurrent hemorrhage. But in addition, poorly controlled hypertension, race, and some evidence in amyloid angiopathy patients that ApoE genotype that's been identified as a genetic risk factor for Alzheimer's disease is also associated with risk of recurrent amyloid angiopathy-related hemorrhages. And so it's reasonable to incorporate these into decision-making that is based on the prediction of recurrent hemorrhage. And then I'll turn in the last few slides to prevention. And this, again, goes very much back. This is an older study, the Progress trial, and the Trident study that Dr. Anderson talked about will be a substantial step forward in our understanding of how to use blood pressure treatment, how to apply it in practice to reduce risk of recurrent hemorrhage. But you can see the results from the Progress study that this was a study of all stroke types, but whether the in which individuals were randomized to this perindopril with addition of indapamide to aim for a blood pressure target, and whether the qualifying event was a intracerebral hemorrhage or the outcome event was an intracerebral hemorrhage. In both cases, if anything, the sensitivity to blood pressure control was greater for preventing recurrent hemorrhage. So I think this really reinforces Craig's point that we think blood pressure is a key factor across the board in stroke, but probably nowhere more so than in prevention of intracerebral hemorrhage. And so here I am really just adding on top of the strong data shown by Craig and excuse me, this really universal guideline to aim for close blood pressure control. And based on the data I showed, this would be true both for hemorrhages felt to be due to arteriosclerosis, but also those felt to be due to amyloid angiopathy. A broad question that is probably the thorniest one that we deal with in prevention took a lot of input from the guidelines writing committee was how to manage, in particular, antithrombotics, but also other medications in the setting of post-intracerebral hemorrhage. So there was felt to be little choice in people with a very high risk setting, such as mechanical valve or an LV assist device, where early resumption of anticoagulation was felt to be reasonable. The much thornier questions of weighing out benefit and risk were restarting anticoagulation, typically in people with non-valvular atrial fibrillation. And you can see that those black boxes that say benefit greater than risk or risk greater than benefit really subsume this very complex calculation in any individual of weighing the two sides of the scale, where on the one hand, there may be situations where resumption of anticoagulation may be reasonable. We will have more randomized trials, but they had not emerged and had not largely emerged yet to help guide this decision. If you are going to reinitiate, the recommendation was to reinitiate at 7 to 8 weeks after hemorrhage is the best balance between not causing further expansion of the recent hemorrhage while getting that benefit in place to prevent the future stroke. And that antiplatelet therapy was felt to be reasonable, particularly based on the restart study showing no increase of intracerebral hemorrhage following restarting of antiplatelet treatment. On the other hand, if people were felt to be at too high risk for resumption of anticoagulation, the consensus was that left atrial appendage closure may be considered in those situations. There's equivocal evidence on whether statins increase the risk of hemorrhage. So that was, as a result, this very loose guideline of saying that the benefits and risks are uncertain in the case of using statins following intracerebral hemorrhage. And for the non-steroidal anti-inflammatory medicines, it's not that the hemorrhage risk with them is necessarily higher than with these other medications, but because in most situations they're alternatives, they got a class 3 recommendation against use following intracerebral hemorrhage. And here's my last slide, really just summarizing what Dr. Anderson spoke about quite well, which is the broader group of lifestyle modifications associated with recurrent hemorrhage risk, and also broadly the large role that the family and caregivers play in both enhancing recovery and in instituting healthier lifestyle to prevent recurrent hemorrhage. And these were felt to be key areas for focus by the guidelines committee. So with that, I thank you, and I will turn the slides to my co-chair and colleague, Dr. Ziai.
Thank you, Dr. Greenberg. Great. So we're now going to tackle ICH guidelines part 2. And these are my financial disclosures. None are particularly relevant to this talk. And I'm going to go through recent advances in acute care, treatment, and medical complications, and how these relate to functional outcomes and mortality. So the organization of healthcare systems, of course, is an important component of optimal stroke care. And the guideline does recommend developing regional systems that provide the initial ICH care, and then when appropriate, allowing rapid transfer to facilities with neurocritical care and neurosurgery. I'm going to talk a little bit about what data needs to be accumulated still. And so data on what types of public health campaigns and which pre-hospital strategies translate into improved outcomes are limited. And that includes the role of mobile stroke units and CT scanners. Now, this is the initial laboratory workup of acute ICH, which includes all of the specific tests that have targeted therapies that could improve outcome, or they confound the clinical picture and require other types of urgent treatment. And There are a number of tests that are either not widely available, such as specific factor 10A inhibition levels, or haven't been shown to improve outcomes in ICH, such as thromboelastography or TEG, or are of unknown utility for acute therapies like platelet or coagulation activity assays. Now, if we consider blood pressure control, where we have some of the largest clinical trials in ICH, it's now considered beneficial to use treatments that limit blood pressure variability and achieve smooth, sustained blood pressure control to reduce hematoma expansion. And ideally, we should try to treat within 2 hours of onset, reach the target within 1 hour, aim for a systolic blood pressure of 130 to 150 as a safe target, and avoid going below 130, which is potentially harmful, especially with regards to renal adverse events. Now, we don't have a lot of well-established blood pressure guidelines for very large ICH, initial blood pressure greater than 220, ICH requiring surgical decompression. Much of the data is based on deep ICH, and whether ultra early blood pressure lowering or beyond the first 6 hours is beneficial is not that well studied. Now, we do have well-established protocols for the management of anticoagulant-related ICH, where the treatment of DOAC reversal should be generally administered based on type and timing of anticoagulant rather than waiting for the results of blood tests. 4-factor PCC superior to plasma for warfarin-associated ICH together with intravenous vitamin K. Reversal of the anticoagulant effect of the DOACs can be done with the specific reversal agents, itolizumab and andexanet alpha. However, relatively few clinical data on the effectiveness of these agents in preventing hematoma expansion or improving outcomes. And in the real world, clinicians still need to balance the expense against the benefit of these drugs. And when the specific reversal agents are not available, activated or 4-factor PCC may still promote hemostasis in the patients on DOACs. Again, we need more data on utility of anticoagulant tests for the DOACs. And there is a new agent, siraparantag or aripiprazine, which is a universal antidote for all anticoagulants and is awaiting results of phase 2 and 3 trials. For antiplatelet-related ICH, there's still no convincing benefit for platelet transfusions and desmopressin. And in fact, platelet transfusions are potentially harmful, except for emergency craniotomy, for which platelet transfusion might reduce postoperative bleeding. There are mixed results for desmopressin from the retrospective data. And some of the knowledge gaps here concern the effects of reversal of antiplatelet agents other than aspirin and the benefit of platelet transfusion for other procedures, as well as clinical trial data for desmopressin and clinical effectiveness of the monoclonal antibody against ticagrelor. For recombinant factor 7A and tranexamic acid, large trials have shown modest effects on limiting hematoma expansion, but unfortunately, this has not translated into improvements in functional outcome. The presence of the CTA spot sign or other CT indications of hemorrhage expansion, which you just heard about, did not predict beneficial response to either of these hemostatic agents. So the uncertainties about these agents are related to the time window for administration, which patients are at risk for hematoma expansion, and whether there is an ICH volume threshold. There may also be potential synergistic effects of combining the therapies. On to provision of care in specialized multidisciplinary units, which is recommended, especially for patients with hydrocephalus who may need neurosurgical management. However, more prospective studies are still needed to confirm which patients are best cared for in various settings, as well as the optimal timing and care bundles for transfer to appropriate facilities. Now, there's large trial data showing evidence of early implementation of treatment protocols that monitor fever, hyperglycemia, and swallowing dysfunction in acute stroke units, which decrease length of stay, mortality, and disability even over the very long term. However, early predictors of patients at high risk for infection or delirium are not yet validated for our clinical use. Regarding thromboprophylaxis, from registry data, insertion of an inferior vena cava filter does reduce the mortality from pulmonary embolism-related death, and starting low-dose or unfractionated or low molecular weight heparin for prophylaxis at 24 to 48 hours from onset may be reasonable to prevent thrombosis relative to the risk of expansion, although it also may be reasonable to first document that the hemorrhage is stable on a CT scan. And based on some retrospective data from traumatic ICH, starting therapeutic anticoagulation at 1 to 2 weeks after onset did appear safe with regard to hematoma expansion. We still need data on the optimal timing of initiation of anticoagulation for venous thrombosis. The optimized serum glucose targets for ICH patients are largely derived from the medical ICU literature and the NICE sugar trial, which found that a target of less than 180 milligram per deciliter is associated with lower mortality compared to 81 to 108 and less likely to result in severe hypoglycemic events. While treating fever, of course, is reasonable to improve functional outcomes, the utility of induced hypothermia to decrease perihematomal edema is still unclear. Seizures. So new onset seizures are relatively common, usually within the first 24 hours, but prophylactic use of anti-seizure drugs is still of unclear benefit, and the recent studies haven't consistently identified harm or benefit in terms of functional outcome or seizure prevention, although specific domains such as cognitive function may be negatively affected by these. For monitoring patients who have suspicion of seizures, continuous EEG monitoring for at least 24 hours is probably reasonable. The relationship between seizures, outcomes, and the impact of anti-seizure medications is not yet well defined, and there's no clear consensus on which abnormal EEG patterns have prognostic significance. The primary recommendation for invasive monitoring is ventricular drainage in patients with hydrocephalus, and the indications for the use of an ICP monitor are much less clear for ICH. Hyperosmolar therapy may be considered to improve outcome for transiently reducing the intracranial pressure, but prophylactic hyperosmolar agents haven't demonstrated efficacy, and corticosteroids really don't have a role for treatment of elevated ICP for ICH. Now let's talk about surgery. So there is enthusiasm for minimally invasive techniques to treat moderate to large ICH. It seems intuitive, but the results from large randomized clinical trials have not yet been definitive. And minimally invasive hematoma evacuation with endoscopy or stereotactic thrombolysis is safe, may reduce mortality, but there's uncertain effectiveness for functional outcome benefit. However, compared with conventional craniotomy, minimally invasive techniques may actually improve functional outcomes, but this may simply reflect the practice to perform a craniotomy, but not minimally invasive surgery in patients who are deteriorating. The RCTs of minimally invasive surgery have not addressed the a priori questions about timing of surgery and the intent to stabilize the clot before going to operation, nor have they compared the different devices available for use in minimally invasive surgery. For intraventricular hemorrhage, insertion of an external ventricular drain to treat intracranial hypertension and remove blood does improve survival with, again, uncertain functional outcome benefit. And the same is true for addition of thrombolytics such as alteplase, and similarly for neuroendoscopy. Here, there are no specific recommendations for selecting patients with IVH who should have an EVD placed, and no adequately powered clinical trial data to compare the different surgical approaches for evacuating intraventricular hemorrhage. Craniotomy for patients with supratentorial ICH is of uncertain benefit still compared with medical management alone, where the large clinical trials have been inconclusive, but it is reasonable to consider craniotomy as a life-saving procedure in deteriorating patients. An important knowledge gap here is the timing of craniotomy, where there are some small randomized trials requiring surgery within 12 hours that have suggested benefit compared to the larger stitch trials, which didn't show an early time effect, but where most patients did undergo surgery well beyond 12 hours from onset. For cerebellar hemorrhage, despite a lack of randomized evidence, hematoma evacuation is often recommended to reduce mortality in situations of hydrocephalus, brainstem compression, and herniation. And data from a large individual patient data meta-analysis has added the indication of large volume hemorrhages greater than 50 milliliters in the cerebellum to reduce mortality. The effect of surgical evacuation of cerebellar hemorrhage for improving functional outcome remains uncertain, as is the timing of surgery for cerebellar ICH, where initial conservative treatment may even be preferable in patients who are in good condition. Again, different surgical approaches for cerebellar ICH have not been compared. For large supratentorial ICH with coma and refractory intracranial pressure elevation, decompressive craniectomy is still often considered a life-saving procedure despite lack of strong randomized evidence. But again, efficacy of decompressive surgery to improve functional outcomes is uncertain, and the time windows for the benefits of surgery and the patient-specific factors are not well established. Finally, Mood disturbances and cognitive dysfunction are very common after ICH. Post-stroke depression occurs in up to a quarter of patients by 1 year, and dementia occurs in up to 30% at 3 to 4 years. So screening tools for depression, anxiety, and cognition should be performed in the post-acute period. Moderate to severe depression should be treated with evidence-based treatments, and for cognitive impairment, it's reasonable to refer for cognitive therapy and consider cholinesterase inhibitors or memantine, and for mood disorders, SSRIs, although there is, of course, uncertainty about individual medication choices due to the risk of ICH for specific SSRI medications, and whether we should use the same pharmacologic agents to treat post-ICH cognitive decline as we use for Alzheimer's disease and vascular dementia remains unclear. I'd like to thank the group that produced many of the educational slides that we've been using, and thank you very much.
Hello, while everyone's getting their cameras on, I want to thank the speakers. These talks were really amazing and very comprehensive. Thank you for those of you who have put questions into the Q&A box. I'll do them in order. This one's for Steve Greenberg. In your recommendations for more extensive imaging, you used an age threshold of less than 70. What about someone over 70 years of age who does not have a history of hypertension or trauma or have other high-risk conditions? What do you recommend?
Right, yeah, it's a great question. And the guidelines, of course, focused on the highest yield scenarios, in particular for selection of people to recommend DSA, where we know there's a risk as well as cost involved. There's cost, but not so much risk for non-invasive imaging like CTA and MRA. But those guidelines are not meant to say that people outside of those groups have no possibility of having a macrovascular cause, and it's certainly reasonable in the depending on the situation to do further testing. But in that scenario, somebody over 70, other causes, even in the absence of vascular risk factors or trauma or other etiologies, things like amyloid angiopathy, which can certainly occur in the absence of hypertension or other vascular risk factors, become more common because of the steep age relationship. So that therefore the yield of invasive imaging goes down, not because other causes don't occur, but because things like amyloid angiopathy becomes the dominant cause. So I think the approach is to have the highest scrutiny for people who fit in those categories, also to consider in select situations when to use particularly invasive imaging methods like DSA in people who are outside those groups where the yield is likely lower, but still not zero, depending on the situation.
Great, thank you for that. Craig, the next question was targeted to your talk. It has to do with the contribution of anticoagulation, particularly in combination with hypertension. Do you see any interaction there?
Look, the data on anticoagulation and ICH is that the bleeding tends to be more protracted and larger in comparison to those anticoagulation free, and that has a bearing on outcome. And there is an interaction, a significant interaction between levels of blood pressure and anticoagulation. So it is important, obviously, not only to reverse anticoagulation, but also to control blood pressure. In low resource environment, there's less anticoagulation. So I think as we're getting older and there's more atrial fibrillation in high income countries, then anticoagulation related intracerebral hemorrhage is increasingly, I think now probably accounts for about 5–10% of cases.
Great, thank you. Wendy, I'm going to pose the next question to you. It has to do with the DOACs And clearly, the clinical trials that compared DOACs to warfarin showed a lower risk of intracerebral hemorrhage. But in the real world, are you seeing a high volume of intracerebral hemorrhage in patients taking DOACs? And do you notice any difference in their outcomes?
Yeah, I think that's an interesting question, because now we are seeing a transition certainly away from warfarin and towards use of DOACs exclusively. So we're not seeing as many warfarin-related hemorrhages anymore. I think overall, and consistent with the data, the hemorrhages may be a little bit smaller, perhaps less severe with the DOACs. There is some data that suggests the outcomes are better, but again, there's so many factors involved in appropriate reversal of the DOACs and the age group in which these occur that I think we do need more data still. But generally, it is thought that the hemorrhages are less severe with DOAC related hemorrhage compared to warfarin.
And Wendy, when you're reversing anticoagulation from any of these agents, do you have specific time targets for how quickly reversal should be instituted or successful?
Yes, that's become a very hot topic lately, at least in the neurocritical care world, where perhaps we should be spending more time in the emergency department and paying attention to the time of reversal. We do not have a particular protocol for time to reversal. It's obviously as soon as possible, but certainly I believe that the earlier we can, obviously the earlier we can do this, probably the better when it's indicated. And I think there's going to be a movement towards trying to achieve perhaps guidelines with respect to time to reversal as as even part of comprehensive stroke guidelines in the future. That's the movement.
Great, thank you. Craig, there's a question about fruit intake and intracerebral hemorrhage. Do you want to talk a little bit more about that?
Yeah, look, the major component on fruit is potassium. So there's very good epidemiological data of dietary intake of potassium in relationship to cardiovascular disease, and particularly the data for intracerebral hemorrhage. How does potassium work in controlling blood pressure is a little uncertain, but probably related to renin-angiotensin feedback mechanisms in the kidney. And then obviously sodium is much stronger data in relationship to hypertension and cardiovascular disease. So what component of the low sodium potassium enriched salt works is a little uncertain. Probably the combination has a synergistic effect. I think ethics committees would probably be a little uncomfortable of us prescribing a slow K tablet to everybody, but having a banana or an apple or an orange every day is very safe and effective.
Great, thank you. Wendy, a question on the ENRICH trial, and maybe your thoughts about how you figure in minimally invasive surgery in your current practice.
Yeah, that's an interesting question at this particular moment in time, where we've seen a trial that was successful and that was conducted during the COVID era and has now been completed with an abstract presented. I haven't seen a final published paper as yet. It's an encouraging study. I think it confirms the prior signal from minimally invasive trials such as MISTI-2 and ICES and MISTI-3 and others. It does, I think, also still confirm the need for a larger definitive trial, but it showed that the procedure, MIPS, was safe for lobar ICH, certainly, and resulted in substantial clot evacuation and improved the utility-weighted modified Rankin score at 6 months by a small amount, but relative to standard management. And so, I think it's a very encouraging trial, and we look forward to seeing the final data and looking at what went on in the deep hemorrhages relative to the lobar hemorrhages, and the final distribution of the Rankin scores across all groups.
Great, thank you. Steve, it's not uncommon to get MRI scans and see evidence of cerebral microbleeds or superficial siderosis, even in patients who haven't presented with a fulminant intracerebral hemorrhage. How does that affect your thinking about starting antiplatelet therapy, anticoagulation, or delivering thrombolysis?
That's a great question, Karen. And it's, as you, I mentioned, for the first time, even though our committee was charged with treatments for people who've had intracerebral hemorrhage, this is the first time we sort of dipped our toes into primary prevention questions, such as somebody who's never had an intracerebral hemorrhage but has only microbleeds or only cortical superficial siderosis. From population studies, microbleeds are really common. Superficial siderosis is less so, although it does exist even in people selected from the population for study. I think there's the recommendation was a very soft one, saying that it was here are the factors that appear to be, here are the findings such as cortical superficial siderosis that do appear at a population level to be associated with increased risk for future hemorrhage, but how to actually incorporate that into decision making is unclear. I think there's the danger of going overboard and withholding treatments that are beneficial. First ever hemorrhage is almost certainly a lower risk than recurrent hemorrhage in almost every situation. So my own practice is very much a case by case one, but I think the burden of proof is to identify situations where you wouldn't use either antiplatelet or anticoagulant medications that are otherwise indicated, because we know what the benefits are, and until we can better define the risks, it's not clear we should be withholding them. I think it's certainly reasonable. There, as Wendy said, that the trend has been very strongly towards using DOACs. In general, I think there's a stronger argument to use DOACs in people who have one of these higher risk features, such as multiple microbleeds, in preference to warfarins, my own practice. As I say, to the extent that we have any data, antiplatelets are clearly a lower risk than anticoagulants, including DOACs. So I think in most situations, the answer is not to overreact to the finding of incidental microbleeds and still to provide treatments that are clearly have benefit for prevention of cardioembolic or other non-hemorrhagic events.
Great, thank you. I have a question. I'd really like to get the opinion of each of you as to the blood pressure target of 130/80. A member of our audience asked if that should be the target, and I'll ask, should it be lower? Do we have strong enough evidence that is the correct goal for management? Craig, do you want to start off?
Yeah, look, in the progress study that Steve Greenberg referred to, the treatment effect for intracerebral hemorrhage was 50%. And, that could be real, but it could just be chance because it's a subgroup. So it came as a surprise to us on the progress trial. And so, and then the other thing from the trial is that there was no U-shaped relationship that we often find in other cardiovascular studies, that once the blood pressure goes down below 130, there's an attenuation of the benefit and even maybe an inversion for harm. But for intracerebral hemorrhage, we never showed any lower level of harm. So theoretically, the lower your blood pressure, the better. But you see, most of our patients are elderly and frail, and we still have this concern that we're going to cause the patient to be dizzy and have falls. So there's hesitation. But epidemiologically, clinical trial data, you have your blood pressure as low as you can tolerate it. But obviously, if the person is a bit frail and older, we just have to be a bit cautious. But definitely, if you're old, it doesn't mean that you have to go soft on your blood pressure, and this is a big problem. We think, oh yeah, maybe we're old, you've got to have the blood pressure up a bit for cerebral perfusion, we've got to be careful. The elderly need blood pressure control even more than the young person.
Thank you. Steve?
Yeah, of course, really well said, Craig. And I think if we could even get everybody to the target of 130/80, we would be very happy with the way we've been able to deliver so much benefit. But the question of, whether lower is better, I think I agree with Craig's reading that there's no evidence for any kind of J-shape in terms of triggering future hemorrhage. So from a purely hemorrhage prevention standpoint, yeah, I think I'd argue that lower the better. Of course, there are other considerations besides hemorrhage prevention. So the question of whether renal injury or or falls or other things, but those would be outside of hemorrhage prevention. I think from a hemorrhage prevention standpoint, we don't have any evidence that there's a too low or a point where there's no longer benefit.
Great, thank you, Wendy.
I concur fully with the remarks that have been stated. I will say that I don't think we know fully when the time should be after an ICH to start lowering blood pressure to less than 130. And since I'm in the sort of acute phase of looking after these patients, I would say that we need to be a little bit hesitant about doing that too quickly. And there are patients with very large hemorrhages who may be harmed by bringing blood pressures well below 130.
Excellent.
At least in the acute phase. Yeah.
Great. Well, we're at the top of the hour, so I'd like to thank you all for joining us today. An email with credit claim instructions will be sent out to participants after the event. This webinar is part of a series of webinars throughout the year in collaboration between the World Stroke Academy and the American Stroke Association. Thank you to everyone, especially our exceptional speakers and all the support staff at WSO and the American Stroke Association who helped in today's presentation. And thank you to our audience for sharing your questions and comments. Thank you very much, everyone.